So I'm going to introduce the first Simon. It is Professor Simon Travers. Professor Travers is one of the UK's leading gastroenterologists, and he's also the immediate past president of the European Crohn's and Colitis Organization, abbreviated as ECCO. He is also fellow of the Lineker College at the University of Oxford, and also consultant gastroenterologist at the John Radcliffe Hospital in Oxford. Professor Travers qualified from St. Thomas Hospital, London, back in 1981, and he was trained in gastroenterology both in London and in Oxford, where he did his PhD on colonic epithelial electrophysiology. And he was formerly the chair of the Inflammatory Bowel Disease section of the British Society for Gastroenterology between 2002 to 2005. Also a council member of the British Society of Gastroenterology from 2004 to 2007, and chair of the scientific committee of ECCO from 2007 to 2010. His clinical and research interests focused on clinical prediction, novel therapy, and also endoscopic assessment for inflammatory bowel diseases. And he is author of many books, chapters, and over 200 papers, and many international guidelines. He is also specialized in colonoscopy and a range of other GI treatments. Currently, Professor Travers is also consultant gastroenterologist in the Oxford University Hospitals of UK. His talk today will be on inflammatory bowel diseases, a Western disease coming to the East. So without further ado, let's welcome Professor Travers.
Dr. Weil, thank you very much indeed. And it's an honor and a pleasure to be here in Macau for my first time. And thank you to Mr. Patrick Nguyen and the Stanley Ho Medical Foundation for putting on this symposium in personalized medicine. Now, I'm conscious that for many people, inflammatory bowel disease is not your universe in the same way that it is my universe. And some will not be familiar with inflammatory bowel disease at all, covering chronic inflammation in the gut, ulcerative colitis, and Crohn's disease. But when we're talking about personalized medicine, managing chronic inflammatory disease is very much our today and is most certainly our tomorrow. And the concepts that I will propose are in many ways generic and transfer across specialties as we battle to deal with the overwhelming number of patients that we see in our clinics and try to tailor our treatment, inadequate as it is in many cases, to those individual patients. And in that respect, IBD is a good starting point. And the reason it's a good starting point, because my goodness me, it is coming to the East. This is a slide I borrowed from Professor Su Ng from her work at Chinese U, and from when it was first described in 1859, ulcerative colitis in the Western world, it has been increasing, not quite exponentially, but look how it's mirrored in East Asia and other industrialized countries as globalization has happened. And for again, borrowing from her excellent work on the epidemiology of inflammatory bowel disease in East Asia, she's established a great collaborative international group, and you can see how common it is in Australia, with 24 cases per 100,000 per year, and how much less common it is just down the road in Guangzhou in Hong Kong and here in Macau. But compare that with more rural communities, and you can see that it's even less common, illustrated here, where you see the incidence of just under 3 per 100,000 per year in Macau, similar in Hong Kong and Guangzhou. But in rural China, it is only a tenth of that, although it is increasing, and it's increasing rapidly. I'm not going to explore the reasons why. Of course, you can blame McDonald's or the diet, but actually I think it's to do with bugs in your gut. But it's increasing so rapidly that by 2025, which is not so very far away, then even if it reaches half the current prevalence that it is in the West, there will be more cases in China than there are in the Western world. And it is a particular challenge to newly industrialized economies. And what are we doing talking about personalized medicine? Because when you've got overwhelming numbers of patients, surely the solution is just to have one size fits all. And I don't think we could be further from the truth, because unless we target our treatment effectively at the right patient, we'll be treating many patients unnecessarily, and I'll give some examples of that. So I'm a clinician. I do 5 outpatient clinics a week. I'm not a laboratory scientist anymore. And we'll start with a case I saw just in January, which will be familiar to the clinicians in the audience. She was a 39-year-old civil engineer who came with a 6-week history of bloody diarrhea, going half a dozen times during the day and sometimes at night. She had cramps, no fever or systemic symptoms, and she was given by her local doctor an antibiotic in case she had Campylobacter, notwithstanding the length of the bloody diarrhea. There was a relevant history in that she had had food poisoning 5 years ago. She developed diabetes at a fairly young age, and she'd stopped smoking a few weeks before she developed these symptoms. And for people who specializes in inflammatory bowel disease, we recognize that stopping smoking increases the risk of ulcerative colitis. But smoking isn't good for you because it increases the risk. Smoking itself increases the risk of Crohn's disease. Why? We don't know. She drank, dare I say, like a civil engineer, but probably a bit more than she should, and she certainly weighed more than she should do, and there was no family history of inflammatory bowel disease. That's what the lining of her colon looked like. So pretty shaggy, bloody, edematous, and characteristic of this condition of ulcerative colitis. She didn't have a tachycardia, and using the only validated endoscopic scoring system for colitis, then the absence of vascular pattern, the bit of bleeding and the erosions gave her a score of 5 out of 8, where 0 is normality and 8 is the worst you've ever seen. Biopsies confirmed the characteristic picture of ulcerative colitis. Blood tests were much as you expected. Culture and toxin assays were negative, and she was treated in a conventional way. Because she was a civil engineer, she was a busy lady and needed prompt induction of remission, wanted to avoid steroids because she had diabetes, so she was given oral mesalazine at an oral dose and rectal topical, which is very conventional, and she was followed up by our telephone clinic 2 weeks later. At the telephone clinic, run by one of our nurse specialists, she still had some bleeding, and she still had an increase in frequency, although she was a bit better. What did we do? Well, we used a steroid with low systemic bioavailability, budesonide MMX, which targets the colon. She responded to that. A flexible sigmoidoscopy a few weeks later showed improvement, although not back to normal. And after assaying her enzyme activity for thiopurines, we started the thiopurine azathioprine and continued oral pentasa daily. Now that is personalized medicine today. The problem is this. Those are the results of the budesonide at the efficacy trials, 2 efficacy trials in budesonide in ulcerative colitis of mild to moderate severity. And what this shows, the 2 trials, one in Republican red, another in Cambridge light blue. The Republican red study was done in the States, and the Cambridge light blue study was done in Europe. The Oxford blue study of the combined results, and they look pretty impressive until you notice that the percentage of patients that the axis stops at 25% there. So what we're seeing is a 17 or 18% effect for getting into remission, albeit compared with a placebo rate of about 5%. But hey, that therapeutic gap is enormous. It's 83% to getting everybody into remission. And we consider that the state of the art for this steroid treatment today. And you can see how far we've got to go, because we have to treat very many more patients who don't respond, and we have no way of identifying it. Lest people believe that they want a reference point for what the current standard of care using Azicol or another type of steroid still only achieves about 12 or 15% remission. Certainly the definition of remission contributes to that very low rate, because we had a very robust definition of remission. But if I am a patient, I want complete control of my bowels, normal stool frequency, no bleeding, and mucosal healing. And that's what those figures show. So what are we going to do about it? Because as Richard Sykes said, most of our drugs don't work for most of our patients. And it's pretty shocking when you look that some of the commonest prescribed treatments, statins for instance, for reducing the risk of cardiovascular disease, the numbers needed to treat to gain one patient with benefit is 25. And it is a shocking indictment of our treatment, where new drugs coming to the market cost in multiple millions in order to have a drug with that effect side. So we need a revolution in thinking. And that's where I go a bit conceptual. So forgive me for those practitioners who everyday clinical practice, but these are important concepts to understand when you're thinking about personalized medicine, because unless we think differently, then we're going to be in trouble. So this is where the concept of omics come in, and omics is just a suffix which is used to describe the totality of any complex system, and with it has come to define the individual fields of study. You'll hear much more about genomics from Peter Donnelly and Simon Leedham shortly, but with it the concept of the complex immunological system, perhaps call it the immunome, or the gut microbiota, the microbiome, the metabolome, what they actually produce, and the proteins from the genes, the proteome. And IBD is an interaction between genes, yes, but they don't account for that rapid increase that Sue and colleagues and others have demonstrated. Nor, but there's an interaction with the environment called the exposome. The bugs in the gut, I think, are pivotal, and yes, the immune system. But look where our treatment is directed. 90% is directed at immunity, with no regard to prevention, as Patrick Hoon was talking about, with the preventing IBD occurring in the first place. And as for looking at the microbiota. Sure, everybody has yuck stories to tell about fecal microbiota transplant, and the treatment, is this going to be tomorrow's world? Well, I think I would reserve judgment on that at this moment, although I do believe that microbiota are key to the pathogenesis of this chronic inflammatory disease. And so with this revolution in thinking and those different omics, then you need to bring them together as the interactome. But how on earth do we study it when you look at the numbers? Because I'm not a mathematician, and there's some outstanding mathematicians in the audience, but if you've got 25 or 30,000 genes, and you've got they're producing maybe 1 million proteins each, and then their metabolic products, and the concept, if you multiply all those together, comes to impossibly large numbers of to address if you're thinking about the possible ways that they might interact to cause disease. So we need to think about networks, and the networks between the exposome, the genome, the microbiome, the immunome, and indeed the other the otheromes, allows, if we can understand the molecular mechanisms around those networks, then we have an opportunity to change the pattern of disease and be more precise about our medicine. And if we're going to achieve that, we need a new system of thinking, and that's where the concept of systems biology comes in, because the approach by routine collection of material from all of your patients and systematic analysis is a way of understanding the bigger picture by putting the pieces together, as opposed to the reductionist approach that traditional medicine and science has taken. To give an example, if you take those different omics, and in the current way we look at them as individual concepts because it seems too difficult to be embracing them all together, and we follow like tram lines, the steps in the approach to gaining more knowledge, applying it to the individual, and creating drugs. Whereas if we combine them in a way by systematic analysis, then we have the opportunity of looking at the primary mechanisms and ultimately developing new drugs for personalized therapy. And to give you an illustrative example of this, it's a matter about creating clusters and understanding through clusters, because in this cluster map of T-cell biology, you can see there are certain nodes within which control the surrounding networks. And if you understand those pivotal nodes, then they can become the target for treatment for all of these things. Whereas if you're trying to understand each individual pathway, then it's beyond computation. And that's why we need smart mathematics to be able to help us simple clinicians look at the massive data generated by all the systematic analysis to help model the clusters so that we can apply them to our individual patients, and therein lies the hope of personalized medicine. So, concepts aside, how do we improve our practice today? How are you in Macau, how am I in Oxford going to personalize medicine to the best possible ability today? And with it come a number of components. There's a database, stratification, multidisciplinary teams, patient pathways, and then measuring outcomes, and above all, collaborating with colleagues. And I'll briefly touch on those, because you start with a database knowing who you treat. Don't trust the hospital to do that for you, because certainly in my hospital, then the way data are collected and the electronic patient record is really not fit for clinical purpose. It's largely an administrative tool, and it doesn't give you the clinical detail that you actually need. And Holmulig, a great colleague and developmental immunologist and pediatric gastroenterologist in Oxford, has helped us develop this database, and looking at 3,000 patients, genotyping them, and looking in particular, his interest is at monogenic disorders, because some patients with IBD, as we would recognize in clinical practice and typical in clinical practice, turn out to have a single gene disorder. So if you've classified your patients phenotypically, in other words, by their clinical symptoms and clinical features, and you've got their genotype, then you can pick off the few, perhaps the very few, who've got single monogenic disorders. But even picking up those few has a major impact in practice, because they have such an impact on the healthcare system. Let me just give you one brief example of a chap who actually came to Oxford at the age of 18 for a second opinion of his Crohn's disease, where in fact he presented as a toddler with recurrent infections and found to have congenital cyclical neutropenia, treated with GCSF. Expensive treatment, yes, but it had kept infections at bay. But then, as a 10-year-old, he developed abdominal pain. He had colonic ulceration, stricturing disease, and he was diagnosed with Crohn's disease. Indeed, 7 years later, as a teenager, he had a resection, a right hemicolectomy. And then, when he came to us, he was in and out of hospital almost every 2 weeks. He was dependent on the GCSF, also dependent on steroids, and we decided to look, with that history, at his genotype and the function around the rare monogenic immunodeficiencies which had defied diagnosis up in Coventry and Birmingham. And we considered there were a number of options, both experimental, the expensive anti-TNF therapy or the anti-integrin therapy, but we felt that if we could be precise about the diagnosis, then there was the opportunity for stem cell transplant. Whilst we were waiting for the results of whole exome sequencing and the functional assays, we tried another anti-TNF agent and then an anti-integrin with really limited effect, before, in fact, he was identified with an extremely rare mutation in G6PC3, which meant that he had dysfunction of the glucose 6-phosphatase system, which was affecting his neutrophil function. And so we advised, since this was a defined monogenic disorder, stem cell transplant. After some discussion with the hematologists, who were initially rather horrified at the thought that we would be putting somebody through an allogeneic, in other words, somebody else's stem cells for stem cell transplant, which carries a mortality of about 20-25%. They were horrified about us proposing that for somebody with benign disease, in other words, who didn't have the label of cancer. We made the case that this was anything but a benign disease. It was had a highly malignant effect on his lifestyle, and he was all up for it. And his parents, after some deliberation, agreed that he went through that. That happened. He spent just over 3 weeks in hospital, and we've barely seen him since. This is a cure. I'm sure it has cured this lad. And that is after 18 years of GCSF treatment, recurrent admissions, the massive burden on healthcare of just this single patient, and we've had others as well, which I think is why being sure about what you're doing is treating really matters. And although that seems too arcane for everyday practice in Macau, it isn't. And the reason it isn't is this, is that it comes down to you and me taking a history. When did the disease start? And thinking about it. And if you had disease starting as a neonate toddler, well, hey, it could be monogenic. What do? All you need to do is to reach into your pocket, pick out your phone, and call a friend who knows something about monogenic disease and can then explore it, which I think is an important message about collaboration. Stratification is, I think, an important part. I'm just going to give you one example about that, which clinicians treating gastroenterology in the audience may be able to apply rapidly in practice, because rather than putting them into a bucket of a diagnosis, you stratify them based on their risk of complications in the future. And because I'm a simple clinician, then I like to keep it simple. And what we did was to look at our patients with ulcerative colitis and came up with this very, very simple formula, which allowed us to predict at diagnosis which of our patients with ulcerative colitis were going to get acute severe colitis in the next 3 years. Acute severe colitis is not only potentially life-threatening, but it is the condition around which colectomy is most common. And simply by taking the extent of disease, the CRP and the hemoglobin at diagnosis, and hey, every gastroenterologist does that for every patient with ulcerative colitis, we were able to predict who would do badly and be within that group of 25% of people who develop acute severe colitis, because we simply applied the number 1 to each of those components. And so if you had extensive disease, if you had a CRP above 10, that's 1 each, that's 2, and a hemoglobin less than the WHO classification of anemia, that gave you another 1. Then if you had 3 out of 3, you had in our development cohort a 73% chance of developing bad disease sometime in the next 3 years. And that's, hey, 3/4 of your patients are going to go sour. We then replicated that both in Cambridge, UK, and in Sweden. And in Cambridge, it was associated in 100% of their patients, and even in Uppsala, which was a completely different population, where only 6% rather than 25% of patients were admitted with acute severe colitis. It predicted 93%. So this is a useful thing which is easily applied in practice. And we need to establish multidisciplinary teams. And those include, yes, surgeons, radiologists, pathologists, and the like. And perhaps it's easier to think of those rather like an orchestra, because an orchestra is carefully organized into the different instruments and every orchestra organized in a similar fashion. And it's all about organizing your care. This doesn't require a lot of investment in money. It requires a lot of investment in time and cooperation between specialists. And of course, in an orchestra, to create music, you start with a score. Let's call them the guidelines, the IBD guidelines for treating care. And then you can apply to each instrument panel a certain clinical specialty. Well, surgeons have to be the horns, don't they? And then you get a range of others, and the trombone for the endoscopist seems a particularly apposite. And then you get the research scientist, the lab scientist, and ultimately you get the conductor, and I leave it to you to decide whether the conductor is the patient or the physician. But that doesn't need to be a whole orchestra. If you work in a smaller group, it can be an ensemble, and it can even be a trio. And what I mean to get across in that is that it's about making music, and good personalized care is about creating harmony by collaborating and focusing on the individual. You can have algorithms, and I'm not going to go through these in any detail because they're well published. I'm always slightly suspicious of medical algorithms because they're two-dimensional answers to a three-dimensional problem, and you can follow those through, and you can refer to the literature for managing IBD and many other aspects. And there is the concept of treating to target, setting your targets, and for colitis it's absence of inflammation, so you've got your clinical and your endoscopic markers, and the argument nowadays in 2018 is that you ought to be setting your treatment targets, rather like treating blood pressure, I suppose, is more familiar. This is unfamiliar territory to us as IBD specialists. And setting those targets and escalating treatment until you meet those targets. Trouble is, we haven't yet shown that escalating treatment carries more benefits than the risks, but that's work in progress. But if we are going to improve the standard of care for all of our patients, then we've got to know that we're achieving those outcomes. At the moment, most of the measures that we are using to judge the effectiveness of medical care has nothing to do with outcomes and everything to assess process. And therefore you need a common language so that we can judge whether the care that we are delivering in Oxford is as good as, better than, or worse than the care that you're delivering here in Macau, because at this moment in time we really do not know. And Professor Sung has spent time at the Sloan Kettering recently, and I thought this was some really interesting work which is not in the field of IBD but in the field of cancer. And what the Sloan Kettering did some years ago now, although only published in JAMA just a few months ago, was to take a group of patients with solid organ metastatic cancer, bad patient population, poor prognosis, and then randomize them to receive either an electronic patient-recorded outcome, so they've monitored their patient-reported outcomes on a regular basis, or the standard of care at Sloan Kettering. And what they saw over a period of 7 years was that simply by the patients receiving or reporting their patient-reported outcome, they got an improvement in mortality. I mean, how impressive is that? That ain't bad, just for patients documenting their outcome. When I heard about the impact of the tyrosine kinase inhibitors in liver cancer there, I think that's actually pretty good, just for having patients measure their reported outcomes. And we've been trying to do that in IBD. I assembled a group of specialist colleagues, but more importantly, patients themselves, patient association representatives from Los Angeles in the west over to Shanghai and Seoul in the east through Europe, and we got together to develop a set of patient-reported outcomes using the strict methodology of the International Consortium on Health Outcome Measures, and we created a will. It's only just appeared in online, and but this is the first time we've had a language that we can use to measure outcomes and have patients documenting their own outcomes. And that's a really important thing, because you would have thought that we ought to be measuring quality of life in our patients with a chronic disease, but we don't. There's a very simple metric called IBD control, which is past one of the PROs of the ICHOM, which is being validated, although not yet validated in other languages, although there's an opportunity for doing that in Cantonese and indeed in Mandarin. But it's a very simple metric to be used for quality of life. And with it, we've gone into digital data collection using something called the True Colors system, because we've got to have to engage our patients in their own data collection. Otherwise, if it's healthcare professionals doing it all, we just won't get there. We'll be swamped. And by using an ulcerative colitis, it's called the True Colour system for pretty obvious reasons, because the traffic light system for severe, moderate, and moderate disease or remission, you can have patients tracking their symptoms using a validated index, the Simple Clinical Colitis Activity Index, and you can see it varying, and you can see with the quality of life measured by this IBD control metric that it mirrors the change, and you can use biological markers such as calprotectin. And with it, we've been able to develop a scoring system for determining, simply by the quality of life, the IBD control, and the symptom index, the SCCAI, of the likelihood of patients needing escalating in treatment at a clinic visit. The importance of that is that in many of our clinics, busy and overwhelmed as they are, we see many patients who are actually well, who probably don't need to be seen, but we follow up because that's what we've always done, and who just want a point of contact, and it's reassuring to know that they're okay and you have continuity of care. But if you're maintaining digital access and you can decide you're going to see those patients in whom there is an 80 or 90% chance of needing to escalate treatment, well, that actually is effective use of your outpatient clinics. And above all, we just need to interact with research colleagues. And this collaboration is so important, and it's how personalized medicine is changing. Because we, as when we were trained conventionally, were used to this individual, one-on-one approach, where the physician or the surgeon was the person, knew everything and applied everything for this individual patient. Well, we must go beyond that, because it's collaborating with colleagues which is going to give answers for on a personal basis. To use an example, some work that we've done on something which is a potential biomarker called oncostatin M, which is Fiona Parry's group led and published in Nature Medicine only just 8 months ago. Identified oncostatin M as predicting non-response to anti-TNF therapy, this expensive $20,000 a year treatment for inflammatory bowel disease. So even when patients had the same clinical activity at baseline, there were some who made who entered remission, others who had a partial response, and others had no response. And what was interesting is the actual expression of OSM tracked that group, and we were able to validate it in a phase 3 style. But there are other approaches which can be used as well, and using the mathematicians' big data analysis, taking routinely collected data such as CRP and crunching the numbers, which we've done with David Clifton and Kate Newhouse working with Holmulig in Oxford, has enabled us to compare the two drugs, adalimumab and infliximab, together, used in Oxford over a 5-year period, to determine that there ain't no difference between the two as far as clinical effect is concerned. And I think that is interesting, because that's not, you cannot get those data from clinical trials which are of short duration. And I think it shows the power of interacting with basic science colleagues, with engineers, mathematicians and statisticians, to inform your practice and tailor your practice to the individual patients. So that's what's happening in inflammatory bowel disease. If anybody is thinking about becoming an IBD specialist, do come and speak to me or Sue, because I do believe that this personalized medicine provides a paradox, because I do think it's the only way of managing increase in demand. We need a systematic approach with systems biology. And what do you do today? Well, stratify patients at diagnosis, identify those with very early onset disease by taking that history, treat to target, work to develop a multidisciplinary team, and use patients as their own data collectors, but also generate those interactions with scientists, because those are the people who are going to answer the questions that your patients ask. And if you're in Vienna, then come to ECHO 2018 in February. Thank you very much indeed.
Thank you, Professor Charles. Okay, it's our Q&A time. We do have a question from the audience. I'd like to translate into English for you.
Oh, I'm very pleased, actually. I could see the dots and dashes, lines, and I need a colleague, a collaborator to interpret, so thank you.
The question is actually asked by one of our audience regarding the use of traditional Chinese medicine in the prevention and treatment of inflammatory bowel diseases.
So that's an interesting question. My PhD on colonic epithelial electrophysiology included examining platelet activating factors, which was derived from ginkgo biloba, which is used as a traditional Chinese herbal medicine for treating chronic inflammatory diseases over the past 2,000 years. So so part of the question is, will that work for IBD? Well, possibly, and there's work which goes around it. And I was visiting the Traditional Chinese Medicine Center in Shanghai only 2 weeks before Christmas, and I think there's a lot that we can learn in the West from that. But you still run into the same problem. It'll work for a proportion of patients, but the majority of patients it won't work for, and it's personalizing it. How do you actually focus on those who are going to have the effect? But it also begs a second part to the question, is could you use it for prevention? I like that very much indeed, and Patrick and I were talking about that yesterday, is what can we do for prevention? Because if the ginkgo biloba extract not only treats it, but could it be used as a preventive? Well, it probably isn't toxic as far as we know. And I wouldn't mind going to the top of our arboretum and collecting a bag of ginkgo biloba leaves and chewing a few if that was going to prevent me getting IBD.
So, do we need a translation?
Any other questions? Oh, please.
Sure.
Thank you very much. I really enjoyed that. One of the key components about personalized medicine also relates to access to healthcare, so drugs, and many of the monitoring tools. I mean, Macau is very unique because it's got one of the greatest access to healthcare and all of the newer sort of agents. But in reality, this is not the case all around the world. So in terms of personalized medicine and IBD, I think what we're going to see is this huge disparity to access to healthcare for those who can and those who can't really do that. And do you think there's a way to overcome that? But for those who can't, does that mean a lesser quality in terms of care?
Well, it's a very, very fair question. I know how much you struggle with these, not only the cost of biological therapy, but the risks of it as well. And if we're going to say that in order to personalize your treatment approach, we need to do a bevy of a dozen tests to be able to find the molecular signature to find the right treatment of you, that's not going to happen in the near future, is it? But on the other hand, one's hope is that since the number needed to treat with adalimumab costing 20-odd thousand US dollars per year is 4, in other words 3 get treatment without any having benefit, then if you can save that sort of treatment, then that money can be redeployed. And bearing in mind what central government is doing in investing in biotechnology here in the Pearl River Delta, I think that you have a chance to lead to be on the front foot there. And I would say definitely you've got a chance to be on the front foot as far as digital technology, having your patients report, as long as we can understand the techniques of responsiveness there. So you are right, there is a danger, as ever, that it becomes a rich man's solution for a global disease. But I don't underestimate the innovation in East Asia for overcoming that.
頭先第一條問題都提到話，究竟中醫藥咧喺防治炎症性嘅腸疾病嗰度有咩作用？咁啊 Professor 咧佢都回答就話佢深信都應該係有作用嘅。佢提到都有人係試緊用個銀杏咁去醫呢種咁嘅病啦。咁啊更加去喺上海嘅中醫醫院都睇到有好多唔同嘅一啲中藥嘅一啲用法咧係治呢個病。咁更加覺得即係如果係預防係能夠達到個預防作用咧，更加係會係好啦。咁但係當呢個係需要多啲嘅研究啦。咁有個佢嘅答案啦。Any other questions?
So actually, I'm not from the medical science, but I'm very interested to know when you mention personalized medicine, and then when you kind of communicate with the patients, how would they react? Because I find that in kind of Asian society, and then a lot of patients, they want something that's standard, uniform, standardized, and not really personalized. So I think when you kind of tell them, okay, I'm going to invent a treatment for you only, and then I guess a lot of people, they might feel uncomfortable in the beginning. And I don't know if it's cultural factors, or does it happen in England as well?
I don't think technical personalized medicine is going to replace the face-to-face empathetic approach of a caring clinician. But I do think that that being able to do that analysis, it's going to be more than just plugging into a wall and watching a computer screen saying, this is what you need, go and get it. I don't think we're doing ourselves as doctors out of business. But you're right, patients are going to be suspicious, especially in our generation over the next 10, 20 years, as we work out the limits and the risks and the benefits. So I do think there will be some resistance, but I think also many patients would welcome it. Coming back to Chinese herbal medicine, 70% of our patients with IBD take herbal or complementary remedies, and that tells me that there's a deficit in efficacy and concern about side effects.
Okay. So in view of the very tight scheduling of the lectures, I think this would be our last question.
I mean, is there any evidence that your personal genome affects your personal microbiome? And would that potentially be a predictor of who would come down with IBD?
Little bit outside my field, and to date the answer is no. I'm going to look here to Sue. Do you know of any other data, Sue? Because you've done work on the way the viro might be related, but there are the twin studies have been monogenic twin studies have shown differences depending on your environment, of course. But beyond that, are there other evidence, Sue?
I think not in personalized medicine, so that there's very different use that should happen in the genome and then have an effect on the microbiome. But I think what we show is just an association between the effects in large scales and all analysis of the microbiome. But I guess the next step would be to look at per individual response and how the genome affects the microbiome.
Thank you, Sue. I'm glad you're in the audience.
So with that, I would like to thank Professor Simon Travis again. Thank you very much.